All right, everyone, welcome, welcome. Are their cameras off probably? Is that how it works? Uh-oh, you're muted.
It looks like yes, but we could certainly ask people to turn them on. I'm sure it's
No, I was just, I mean, I know some people are moving about. So, I'm used to seeing faces pop on, so people are probably putting on their face, getting ready, but hopefully we'll see some faces here soon. I see one coming in now.
there
Thank
we
you, thank you,
go. Yeah, it's hard to kind of talk into the ether, y'all. So if you turn on cameras, it does make it a lot easier.
Okay, thank you so much. And if you need to turn it off, I do understand for some of you. Oh, well, hello, everyone. Maybe I'll see some familiar faces from last time. We're going to be talking about boundaries in clinical practice today, and it's an interactive training. So hopefully we have some few more pop in. Um, Here are a few things about me. I am a clinical director in Georgia. I'm licensed in Georgia, Nevada, and I do telehealth in Florida. I am a clinical supervisor in Georgia, so I have been supervising for, I want to date myself, a few years. So I normally do supervision groups as of late. I also have a company called Why to Live Well, where I do more corporate leadership training, emotional intelligence, diversity, equity, and inclusion, and lots of fun things. I'm an adjunct professor. My favorite courses are trauma, grief and loss, and multicultural. I have a book. Working on a second book. Yeah, I have all kinds of fun things. The most interesting thing that I've done is the legal consultation work on boundary violations. So that has been something new I added during the pandemic because apparently there are a lot of boundary violations going on during the pandemic. So I have been able to learn a lot myself. So we're going to dive in. I always like to start some of these boundary talks by kind of setting an intention and really allowing us to do some quick meditation because some of this stuff is really tough. So we're going to take a few moments to do that. On this slide here. So if you're busy moving around, you'll be able to, oh, let me go back to my slide to see why it didn't pop. Right. So you won't hear anything, but if you could just settle in for a few seconds and allow yourself to be present with what you see, I'll come back and ask a few processing questions when we're done. All right, y'all. Talk to me. Tell me what you noticed. What was coming up for you during that? To me, it seemed like very long minutes. Tell me what y'all thought. Drop them in the chat. Take yourself off mute.
Okay. And I was going to just do it. And
Anyone? Anyone?
I think for me, because I normally do this anyway, but it does have sound most of the time. But for me, these type of things are very relaxing. It kind of gets me back to my center core um, and puts me back in the mode that I need to be in.
heard a piece of what you said. You were muffled. I don't know if you can repeat that one more time. May I be able to?
Sorry, I'm hoping my laptop, sometimes the sound doesn't want to work, but I
Okay.
use these quite often. A lot of times they will have the sound though, and it helps me kind of get back to my center core. It brings me peace and um, kind of gets me back on track where I need to be.
Yeah, thank you. So I heard get back on track from something. Anyone else?
I just appreciate you starting that way. I have incorporated meditation into my self-care recently. Yeah, it was good.
Yeah, thank you. Thank you. Anyone else? Was it difficult for anyone to just focus for that minute? I'll say me.
Well, and
Yeah, so
I
go
hate to
ahead.
want to chime in again, but yeah, when you're in the middle of a busy day, a lot of times it is hard to focus, sit down and focus and, find that minute to do it. But, it's really important that we do.
Yes, yes. I saw a hand. Go ahead. Maybe I saw a hand. Okay. Well, I wanted to take that minute because we're going to be flying through information. So um, I think it's important for us to pause because we'll probably talk about some heavy stuff. So I wanted to give us that space. Elise said she found her mind wandering, even though it was only a minute. Yeah, it seemed long for me as well. All right, so let's go ahead and let me go back here. So these are some of the things we're going to talk about today. I was sharing with Karen that this is typically a 6 hour training that sometimes I cut it into four. Now we're going into three and a half. So you'll hear some pieces of all of these aspects here on some level, and then I may come back and do a part two. But we are clinicians, so we're going to talk a little bit about the ethical code and really just boundaries in practice. We'll have some time to evaluate, break into some groups to talk about some of these common ethical issues that we face. Um, to look at our role as a gatekeeper and what that really means for the profession. We're going to kind of dive into the ethical decision making model a bit. And then my most important area is counselor wellness. I'm, probably going to try to get to that because that is just the most important thing of all in this. And then we'll talk a little bit about telehealth because it's changed the landscape of what we do. So that's our day. It'll go fast today. So I wanted to start with something a little funny. And as we think about boundary setting, there's a dance that takes place when we're advocating, when we're providing support, and we're setting hopefully healthy boundaries. So something funny, what dance comes to mind when you think about setting boundaries with clients? If you're a dancer, give us all the names of your dances. You don't dance, but you want to make up one, you can drop it in the chat or take yourself off mute. Let's see what we got. What kind of dance is coming in? Tango. Oh, yeah. That's a good one. Anyone else?
I don't know if there's a specific like dance that it's called, but sometimes when you're dealing with boundaries, especially with those who are personality disordered, I think about like that the dancing that they did in Footloose, that kind of more chaotic, like just jumping around all over the place type of a thing.
Yeah, that one. I don't know the name, but you described it very well. Thank you. Not the cha-cha, because you just kind of. Anyone else? Any other dances? Let's see. No other dances. Well, just think about that because again, we'll be talking about that throughout the presentation. Oh, somebody said the box step. It's cute. Um, so, we're going to talk about, what is our role as a counselor? If you've been providing services in different aspects, if you have a private practice, if you've done community-based work, if you've been in the profession for quite a bit of time, you have probably identified what your role is as a counselor. So, what do you think your role is as a counselor? What is your role when working with clients? And as you're sharing, I was able to find some roles that may not fit what we do. And social media gives us a lot of roles that really don't align. I know that um, one of our roles is to educate and to, on some level, teach and guide our clients. It's, to hold space for them when they're going through difficult times. But what do you think um, our role is? All right. So, some of the roles that we play, um, we protect our clients and ourselves. We teach and we guide. We are gatekeepers for the profession. It is our role to practice wellness. And then it's our role also to make sure that we are, taking opportunity within the professional development realm to make sure that we are able to serve our clients. Someone else said listening skills, empathy, and observation. That is great. That is definitely a role for us as well. Um, so when we think about the context of boundaries, one of the reasons why I developed this training is because early on in my career, because of needing to get hours, not really liking some of the environments that I've worked in, I found myself working in lots of different environments. So I did community-based work, working with kids in the foster care system. I've done rape crisis. I have done suicide assessments in the ER. I've done some EAP work. I've done school-based counseling. Uh, Probably leaving quite a few environments off, but what I found is that the boundaries change very quickly. Uh, what I was doing over here, they weren't doing it at another place. And sometimes it was pretty confusing. But what it really taught me early on is that the context of boundaries really matters. And it really is based on that particular environment, the set of rules. And so we have to pair our code up against some of these other contextual pieces that we're not always taught to do very well. So when you think about client factors, what client factors would perhaps cause you to set a different type of boundary? You can feel free to take yourself off mute or drop your comments in the chat.
Some of the work that I do is with inmates in the jail and the prison setting, and I feel like that does sometimes require a different set of boundaries.
Yes, we're talking about safety and things of that nature. Thank you for sharing. Anyone else?
Somebody wrote they work in a prison and this requires different boundaries as well.
Yeah. Yeah. So I'll share some of the client factors. So some of it is culture, history, trauma, age, gender, their presenting problem, economic class, personality type, spiritual beliefs, physical health, and prior experience with therapy. I had a client who it's been, several years now. I had a client who was referred from a surgeon, and the client had a brain injury. And so the referral came in. I didn't have a lot of details, because sometimes clients don't show for the sessions. This particular client, when I arrived at my office on this day, the client was, well, I didn't know it was the client, but there was a person sitting outside of my office at about 7:30. I typically started my sessions, early. And so this session was at 8:30. And so at about 8:15, I went to look in the waiting room and the client was not there. So I went back into my office at 8:30. There was no client that, came in the door. At about 8:40, I went out and looked again. There was not a client there. So at about 8:50, the client that had been sitting out there at 7:30 walked into the office. And so that was my client. And so typically I don't necessarily let clients show up 25, 30 minutes late, but since he was there, we were going to have a conversation. And what I found um, out about this client is that his brain injury had to do with entering buildings. A piece of a building fell on his head. And so his process for entering buildings is a little slower than others. And so he has a lot of anxiety. So typically what he would do is he would sit out in front of wherever he had to go into and do his own ritual to come into the office. And so that was a client factor I hadn't really thought about. And so I had to determine, based on my scope of practice and my ability to serve this client, was I okay with treatment planning that the client could show up late? And that was one of the goals that we worked on, to get him to enter buildings on time. And so that was a unique client factor that hit that really helped me focus on the context of boundaries, because they do shift, and you just have to document them accordingly. So we were able to work through that, to help him gain that confidence to enter into buildings on a timely manner, because that was going to impact work and a lot of other areas. And so that was one that stood out. Setting factors, we talked about prison and, being in environments that are not, particularly could cause some safety challenges. What other setting factors would cause you to set some different boundaries? Can you think of any?
We have counselors that work in the school system. And so I think sometimes part of the problem is the school says, oh, you're there. We'll just bring everybody to you constantly. It's really having that boundary of, I'm here for certain students, not the entire student body, everybody all day long. And that's kind of something that they have to struggle with too.
Yeah.
People wrote diagnoses, manipulative tendencies,
Mhm.
secondary gains. I don't know if Matthew wants to say more about that.
A lot of times, the inmates I work with, sometimes they will present with different situations when it's a secondary gain, like they want a housing move, or like, they won't tell the full story of like why they're expressing their needs.
Yeah. Yeah. Thank you for sharing, Matthew. Um, Some other setting factors, definitely outpatient versus inpatient. If you're in a private practice, and you're a solo clinician versus a group practice, if you have an own home office or you're working in an agency setting, if you're working with other professionals and you have receptionists and staff, those are some of the challenges as well. What about therapeutic relationship factors? Let's look at these factors. So, modality, if you're an individual therapist, if you are EMDR trained, if you're a brain spotter, if you're doing DBT, some of those modalities would allow some flexibility, and also others are, pretty rigid based on the protocol of the modality. So you may have to stick to certain things just based on what the modality, what the best practice of the modality may be. If you're working with couples, there may be some different boundaries, short-term versus long-term therapy sessions, and the population you serve. Those all are important factors as well. And then the therapeutic relationship factors would be the quality of the alliance. Is this a secure or trusting relationship? Is it at the beginning of your time with a client, or have you been working with this client off and on for 6 or 7 years? Um, Distance relationships, if there's a possibility for a dual relationship, there may be some different boundaries with that as well. And then we have our factors, our culture, our age, our own specific trauma narrative, our gender, sexual orientation, scope of practice, our training, who you trained under. You're trained in the South versus the North. If you have, 1 year experience, you're a millennial therapist, or you've been practicing for 40 years, it all matters in the context of what we do. So those are just some areas there. So we're here because we're talking about top ethical challenges in clinical practice. I've been doing this training ooh, at least 10 or 11 years now. And over the years, I've added because I learned from clinicians that there's more top ethical challenges. But I want us to take a few minutes and just share, based on the work that you do, what are some of the top ethical challenges you've noticed? Take yourself off mute or drop them in the chat. Yeah.
Transference, counter transference, that was brought up.
Mhm. I think that was one of the first things I remember in my graduate program. They always talked about transference and countertransference. And I guess as you are learning it, it's hard to, really apply it. But then when you're sitting with clients, you're like, oh yeah, that's what they mean. I feel it now. My stomach is happening. And so yeah, that's one that is pretty popular as well because it could potentially lead to some type of violation long term. Anyone else?
I was going to put that in there, and I say that even with the experience of always being
Here's
mindful,
something.
you know.
She may not know she's on
Oh,
off mute.
I'll mute.
Uh,
Teresa has said client asked to keep something private. It may be important to share with the supervisor, but doesn't rise to harm to self or others.
yeah, that's a good one. Thank you for sharing that.
oh, sorry, this is Alicia. I didn't know I was
Uh-oh.
talking. I'm the one that transference, transference.
You're really cutting in and out. It's hard to hear you.
All right, can you hear me now?
Yes.
Yes.
I'm sorry. I had my laptop down for the camera. Um, like with transference and counter transference, even if you're skilled and you've been doing it for many years, I think being mindful because you could be desensitized and just being mindful that that can occur. And I think being able to identify it and to be able to process and work through it's just very important. So that's all I wanted to say.
Yeah, that's a great point. I definitely think that um, probably more seasoned clinicians probably struggle with it more. Now, I don't have any data. I'm just thinking about, when you learn this skill early on, you are really you're just really on top of it. But then as you have been working with clients for a number of years, you're right. It's really sometimes challenging to manage that piece. So thank you for bringing that up. Mhm.
Brooke added court-ordered clients understanding the limits of confidentiality because of our need to report aspects of services to court personnel. Yes, I concur. I worked in the court system for a long time, and that's a big one.
Yeah, that's a good one, Brooke. Thank you for sharing that.
Elise wrote, in outpatient settings and community mental health, I feel a pull to help clients in tangible ways, and keeping consistent boundaries is challenging For example, I just need $1 for the bus.
Yeah, yeah. I did a lot of community-based work. And what I found early on, my supervisor really talked about boundary crossing versus boundary violations and making sure, we understand the difference. Sometimes our agencies uh, are not set up for us to really help the clients with the basic needs. They want us to focus on the treatment plan, but when I worked in community-based environments, excuse me, my clients needed shoes and clothes, and I'm working with, their feelings and their emotions, and they're telling me I want to go to school. I am trying to talk to the defects worker about, you know, they're in this foster home and the foster parent is receiving money. Why is the child not at school? That is an ethical issue there. And so I do think we have this, we're right in the middle of, trying to advocate for their basic needs. Because if their basic needs are not met, it's really hard for them to process some of these other pieces. So that is a great point.
Susan wrote, understanding your own traumas and triggers. Oh, we got a lot of comments all at once. And if you'll be beneficial to certain issues brought to you. And Teresa added other clinicians having different boundaries than mine.
Oh, that's a good one.
And Matthew wrote, knowing we'll have different feelings and triggers, what is important to one person may not be of the same importance to someone else.
Those are really, really, really good ones. I'll share some of the ones that I've seen over the years, and it varies based on clients and what you're doing. The ones that stand out is some of the issues with families and couples. That gets pretty wonky. Documentation as well. Uh, Termination. That is something that's not really taught in our master's programs. You get a little snippet of the client has to leave, and then you have these treatment goals, but having a conversation about termination, uh, cultural humility, dual relationship is always a big one because we work and we live in certain areas and there's some intersectionality. Wellness is pretty big. The code of ethics does say that if you're not taking care of yourself, um, you are in violation of the code. It says it clear for LPCs, and I think social workers is changing as well. It's not just there. It's like having sex with your clients is a violation, and not taking care of yourself is an equal violation. There's no trumping the violations. It's really important for us to think of it in that way. So when we think about the ethics, we're here because we have these ethical obligations. I'm going to talk a little bit about what that looks like. So these are basic principles of basic moral principles of ethical behavior. This is much what we said that we would provide our clients on a regular basis. Autonomy means that we have to respect the independence of our clients, even though in our mind we know that they're circling the block, they're coming back lots of times. Autonomy allows us to respect our clients and give them the independence to choose. Um, Within reason, obviously, we do have some things that we have to mandate. We do have to think about safety and all of those things, but based on autonomy, clients they should understand that it's their session and they get to decide what happens. And then we have beneficence, which really speaks to promoting the well-being of our clients. So gatekeeping for the profession, making sure that we can advocate for them when need be. Now, non-malfeasance is do no harm. And when we think about do no harm in the code, it would really speak about, you know, don't have sex with your clients. Make sure that you're being respectful to your clients. Other ways that we could harm our clients is being excited about the modalities that we just went through a training and we want to try it out on a client that's not ready for that modality. Um, how we communicate, the language that we use, what's in our informed consent, what's on our website. Those things are also pretty impactful to clients' well-being as well. Our our practices, our business practices that don't really allow clients to really do well in therapy. Those are things that we want to consider as well. Justice, making sure that we can be as fair and equal as much as we can. I know there's variances in clients based on client presentation, but making sure we're thinking about that. Um, Fidelity, being realistic to your commitments and promises. So if you say that you're showing up for a session at 9, show up for the session at 9. And then being truthful. If you have to have an honest conversation with a client, we're teaching them skills in most cases. So we want to be truthful and honest with our clients because that is a part of their growth process as well. And then we have the levels of ethical practice. They're broken down into these areas here. So when we think about principal ethics, it focuses on a moral issue with the goal of solving a particular dilemma. It establishes a framework to guide future ethical thinking and behavior. And in an example would be asking, is this situation unethical? Then we have virtue ethics. This focuses on the character traits of the counselor. The question would ask, am I doing what's best for my client? We know that mandatory ethics, it deals with our informed consents, what we're required to do as far as our mandated roles. And then we have aspirational ethics, which refers to the highest professional standards of conduct to which counselors can aspire. If you're doing some pro bono work, if you're doing some community work, that would fall under aspirational ethics. So we know that principal ethics is what should I do, and virtue ethics is who should I be. When I think about the two that stands out, aspirational and virtue, which virtue is who should I be in this role, and then the principal ethics is what should I do. So as we think about making ethical decisions, if you've been in the profession more than a day, you've probably had to make some type of ethical decision, some small and some big. And so when we're tackling ethical decisions, it's important to have a model to help guide those decisions. Um, Ironically, there are probably over 50 models that fit into certain categories, different demographics. But this model is straight and plain. It gets to the meat and the potatoes of what we're doing. So when you're thinking about an ethical decision, you're going to identify the problem or dilemma. Well, if you don't get this part right, you're going to be working on something that is really not the issue. So is it with the child? Is it with a mandated reporting situation? Is there abuse? Is there a couple? Is there domestic violence? What is the identified problem or dilemma? What are the facts in the situation and what are the gray areas? Who's involved? Who's the stakeholders? Who's affected? Is there a supervisor involved? Have you considered your personal beliefs about this identified problem? And so there's a list of things that you can consider when you're thinking about this identified problem or dilemma. You also want to identify the potential issues involved. Who's involved? Is it a child? Is it an underage child? Is it a supervisor? Is it another clinician? And then you want to look at your relevant code of ethics, whether it's the social worker code, MFTs, LPCs, psychologists, we all have a code. They're all similar to some point, but there are focus areas in each code that really is important for you to know your code. It's also important for you to know how your board in your state administers the code. Each state is different. I have taught this training in probably 50 states. And it's interesting how the board looks at these codes differently. So you just have to know what your board thinks about your code. Know the applicable laws and regulations, obtain consultation, consider the possible and probable course of action, enumerate the consequences of the various decision, and then decide on what appears to be the best course of action. Does anyone have an ethical dilemma that they would like to share? Something that they conquered, something that was a dumpster fire, something that they're still working through. If you do want to share, take yourself off mute and share. We will all learn from you. I know I am not the only one that's had an ethical dilemma. I know I am not. All right, going once, going twice.
Like, I can
No.
talk a little bit about what just happened.
Okay, okay.
So I had a client, and this is one of the things I said in the chat earlier. I had a client who told me something and she wanted me to keep it private. She didn't want me to tell anyone. And then the next week, she said it's so okay, because I had encouraged her. This was something that she could even have reported to the police. I mean, um, um, so I encouraged her to let me tell, or for her to tell. But she said no, she didn't want to. And then the following week she came back and said, yes, please, you can go ahead and tell your supervisor. And so I did. And so it ended up being a serious incident report. And my supervisor, of course, had said that I should have told originally. And I'm still, like, to me, I'm still like, I would have even knowing what happened, I would have not told anyone if she had I don't know if it's helpful to, I don't think it's I don't think you need to know, exactly what it was. But yeah, that's the one. It's, still, it's very fresh, very fresh.
Yeah, yeah. Thank you for sharing. How do you feel about it?
Um, what happened is I think once I told someone, it kind of exploded into this big thing. And no resolution was ever received. So it ended up, I feel, harming my client more.
Mhm.
And so even though my supervisor says, oh, yes, you should have told us originally, I am still very much, no, I wouldn't, if it happened again, I wouldn't have told anyone.
Yeah, yeah. It gets tough because a lot of times what I find is that the situation either harms us or harms our client on some level. It's really, especially those gray ones. So thank you for sharing your experience, your recent experience. So that's a tough one. Anyone else?
There was a comment. I was serving a Spanish speaking client. She was grateful and presented me with food. In the Latin culture, food is part of our love language. I thanked her and explained I could not accept, but may I place the food out in a common area for other consumers so they could partake if they wanted to.
Yeah, that's a good one. Yep, that's come up in the trainings as well. So I do think that these dilemmas, um, they make us question lots of things. I had a client It's been a lot of years. The client came in for anxiety. We worked together for about 6 months. The client went away because clients come and go as they please. She came back and she noted in the EHR system that she was coming back for anxiety again. I remembered the client, and so client showed up. All of my dilemmas happened early in the morning for some reason. She showed up early and she was extremely anxious. She disclosed to me that she was anxious about childbirth. She was pretty much due to give birth to a child. This wasn't the work we did the last time. So we talked a little bit about her experiences with her previous child. And she had a very traumatic pregnancy. And she disclosed to me that she was due to report in later that day for a C-section, and she was not going to go. I said, "Oh, okay." And so I said, and so I started listening to her, and she became more and more anxious. And then she said, me and my husband decided that I'm just going to give birth to the child at home. I'm not going. And so I was really new in the profession. And so in my mind, I said, I mean, she didn't hear this, but I said, what do I do with this information? Is she harming the child? Is she harming herself? And what is my obligation? And I didn't know at this point. I was really new, really green, and trying to calm her down and do all the things. But I did have enough sense to, ask permission to consult. In Georgia, we had lawyers, social workers they were lawyers and they were also clinicians that would do some quick consultation on really tough cases. I didn't have a consent to really, at this point, talk to her husband, but I knew that I was concerned about her safety. And so she shared this towards the end of the session. So then I also had to think about all of the other clients that I had scheduled behind her. And so I did the quick consult with the social worker who was also a attorney, and he really just guided me on how to document. Obviously, she had the autonomy to leave. There wasn't any laws in Georgia that really protected the unborn child if something happened, and so he just really helped me document. He suggested that I really spend some time helping her reduce that anxiety so she can have a clearer mind, so she can know what choices she's making if she leaves, and to encourage her if she, wanted me to call her husband because she was not in really any position to drive at that point. And so because it was nearing the end of the session, I needed to reschedule quite a few sessions because she was not in a place to drive. So this whole process took about 3 hours. So sometimes when we're thinking about one client, we also have to think about the ethics that come with other clients, making sure they're still served. This client, she did end up going. Her husband came and got her. They ended up going to the hospital and she had the child. But I thought to myself, I'm like, yeah, we have some heavy lifting that we do. We don't have all these answers. They just show up in our office and we don't always know what to do. And when you're sitting with the client, you're making the best decision you can in that moment, good, bad, or indifferent. And so we have to live with those decisions. We take them home sometime. So that was one of the cases that stand out. I did walk through this decision-making model, and pretty much came up with my best possible course of action. So that was mine. Um, let's see one from Matthew. Yeah, these are all good ones here. Thank you all for sharing because it does help because we all have these experiences. Anyone else before we go to our first case of the day? And we'll go into some breakout rooms for a bit. So here's our case. Let's see. A therapist had an intake appointment with a new client. As soon as he looked at the intake, he realized that she is the sibling of a former client. The therapy was brief. The prospective client talked about how she was abused by the sibling expressed lots of issues with the family. I have to get my assistant. That's a run-on sentence, but y'all can figure out the pieces. When asked about the reason for the referral, she said that her teacher referred her for anxiety. During the session, she stated that she wanted to harm her sister and her mom for not supporting her. So you're going to go into your breakout sessions and walk through this really normal case because this happens a lot for some. We're going to spend 15 minutes in the breakout room and come back and chat about it, and then we'll take our first break of the morning. So, Karen, if you can pop everybody in the breakout room, I will try to put the case. I think I can unshare and maybe zoom the case into the breakout room, but you can also take a picture of the case as well. Just talk through the ethical decision making model and how you would manage this case.
Okay, I'm going to put everyone in a breakout room. So just please accept the invitation and we'll see you guys back in about 15 minutes.
Oh, it won't let me put a. I was seeing if it was going to let me. Zoom changes so many things. Sometimes it'll let you put the slide in the room, but I don't see that option.
Let me look and see if it will do it on this end. Or what I can also do is, what if I made you the co-host? Would that help with the options?
Yeah, let's see here. Da-da-da. Yep, it did.
Wonderful.
Thank you. All right. Well, I'm gonna
Um,
walk my dog right quick.
oh, that's lovely. And we'll be back at 11:05.
Okay, see you back soon.
Thank you.
Okay, well, let's go ahead and dive in, and then after we hear from some groups, we will take us a 10-minute break. So you can stretch and get some water. So I would love to hear from your groups, anything that you've talked about. Even if you didn't talk about the case, we still need to hear what you talked about. So whoever wants to share, feel free to do so.
I mean, I can share for group one. So some of the things we talked about was, is it ethical to meet with a sibling of, a client you've already seen? We talked about identifying the duty to warn, like really fleshing out what harm means to her family, what type of harm she plans to do, and if we have to breach confidentiality for that. We also talked about CPS reports, assuming that this was a child. So those are some of the things we kind of walked through.
Thank you, Samantha. Anyone else?
I guess I'm off mute. I'll go. I think one of the things that was interesting to me was we talked about the two things, the sibling, whether we should be seeing the sibling, and then the duty to warn. But it was the duty to warn was much more clear, and we have, all the steps to follow. Whereas with the sibling, that was a little more challenging to kind of like to kind of talk through. And there's a lot more different perspectives on seeing the sibling than the duty to warn. So I thought that was interesting because when I first read it, I wouldn't have thought that.
Yeah, yeah. Thank you for sharing. Yep, it's the lens that we look through, right?
Mm-hmm.
Thanks so much. Let's see. Anyone else?
I, oh, I can speak to group three if you guys like. Yes, the former client was also the current individual that she screened, her perpetrator. I think too, in terms of, I know the team also talked about, there's different layers here. You have the counselor, the school counselor who referred her to services, and also her harmful thoughts, duty to warn. So those are some of the ethical issues. We were talking about how it hits the principal ethics, the virtual, the mandatory. So those are some of the things. I don't know if the rest of the team wants to add.
Yeah, thank you. Anyone else from that group or another group? All right. Well, thank you all for participating in the group. We will have some other opportunities to connect. I do think that talking through some of these dilemmas are helpful because you do get to hear other perspectives, and oftentimes there are multiple ways to conceptualize these scenarios, even when there is a code of ethics, because I have looked at a lot of these cases. It's not always exactly what we would think it is, just based on what the code is. It's still very gray. And so there's always some exceptions that I've learned over the years that it is gray. But thank you all for participating. We are going to take a 10-minute break. So come back at 11:20. We'll go through some more slides, and then we'll be ready for lunch between 12 and 12:15. So enjoy your 10-minute break, and I will see you back soon.
Okay.
All right. Hope you all had a good break. We're going to keep moving through our material and talk a little bit about healthy boundaries. So we know that healthy boundaries creates a framework for us and our clients. It allows a safe environment. It's parameters that allow us to deliver great services. And it does draw a line between self, client, and the professional helper. So when I think about healthy boundaries, the example that comes to mind is when I go to my doctor's office. It's a pretty stale process depending on what doctor you're going to. So you go in, if they still have the window up because of the pandemic, there's some glass there, but typically there's a clipboard. And on that clipboard, it says, has your address changed or has your insurance changed and what time you're coming in? You check that off. If you are giving them a new insurance card, you do that. For me, I go sit in the waiting room for a long time, y'all, until the next person comes to get me to put me on the scale, and I hope the weight looks the way I want it to look. Then they sit me in this really cold room for a longer time, and then they come back and they have computers, so they do their stuff on the computer, ask some questions, and then I sit again. And the doctor comes. And she goes over what this person went over, and then she does her assessment and whatever checks and tests. She leaves, go back up to the front and pay my copay, set up an appointment if I need to. I give blood or whatever the case may be, and then I leave. Now, if I showed up at my doctor's office and they were doing line dancing in the waiting area, or there's any other bizarre things going on, I would say, what is going on here? It never really changes. Nothing over the years look different. It's normally the same stale process, right? So that's the example that I think of, even though we are a little more emotional and a little more connected. When you think of healthy boundaries, it really is like that. There is a line between me and the receptionist and the doctor and things of that nature, and it flows seamlessly in most cases. keep that visual. Think about that when you're out doing your appointments, because that's really essentially what healthy boundaries look like. So when we think about ourselves, we have to really be honest and really do some self-reflection to say, you know, what boundaries have we implemented that we're excited about, or what boundaries do we struggle with? So I want you to take a moment to reflect. You can drop them in the chat, or you can share what boundaries have you been able to set that you're excited to share with us, or what areas do you find difficult as it pertains to your work with clients. And I'll give just a few minutes. This is a pretty experiential workshop. I'm not lecture style. I'm really more connected. That's how I work with my clients. And so we're going to be talking throughout and sharing. So if you have something you want to say, don't be shy. Let's see here. Oh, yeah, self-disclosure. We're going to talk about that. And when you say implement it, you implemented it and it went well for you, or can you share a little bit about
I'm
that to
sorry.
make sure?
I started typing when I hit send too soon because you were going to ask me that. Meaning that I was able to hold the boundary and not self disclose. That I feel comfortable being able to not self disclose. Disclose with a client. That's what I meant.
Okay. Thank you for sharing. We'll talk about that a little later if we get to it. Oh, this is a good one. Valuing her time away from work. Yeah. Yeah, we have a right to take time off and not be contacted by our clients. Thank you for sharing that. It's an act of self-love and self-care. The one that stands out for me, and we'll keep moving, is time. Early on in my career, I used to give my time away to the clients, like giving them 5 more minutes. I was just going to say something so impactful that their life was going to be changed, or it was just this need to give more. And so I went to a lot of workshops that said, oh, set an alarm and do a buzzer and put a sign. And none of that stuff really worked for me until I really figured out the why. Why did I feel like the client was more important than me? Why did they get to get 5 more of my minutes? I only get like 10. I get to go to the bathroom, take a walk, do a mindfulness, talk to my family. Why did they get more of my time? And so I had to really reflect on that and really understand I was at that time trying to please the client, which really caused me to have resentment for the other clients that was not going to get the best of me. And until I mastered that and really did some of my own work regarding that, I was given all types of things away, which causes ethical violations. So I think now it's the clients know what's theirs and I know what's mine. And if they want to drop a bomb at the last minute, we are picking it up during the next session. So that is one that I think I've mastered.
That's interesting that you brought that up, because there's some clients, that they want every second of that hour from me. And I tend to do that. But I'm covering another clinician is out on leave, and her 2 clients, as it gets to be 10 of, they're like, okay, is it time to schedule? And I'm like, oh my gosh. And that's so wonderful to have, that few minutes, in between clients.
Yeah, I mean, it seems like a very long time when you only get like a few of them. So we can't give them away.
Mhm.
Thank you all for sharing in the chat. So Stephanie says, seeing my clients outside of the agency, out in public places like the grocery store. Yeah, and hopefully we'll get to some of that today. It's really important for us, I believe, because I've been doing this for quite some time, and prior to this, I was in HR. So, and because I'm on all types of ethics panels and supervision panels and things of that nature, I, I believe when I graduated in my master's program, I had a lot of fear regarding all of these rules that we were given, like don't do this, don't do this, what happens if you see a client out, and all of these things that really get in our head and it impacts our ability to be authentic in the session. I remember someone telling me that, oh, you cannot live in the same area as your client. And I start seeing clients that were like hour or more away from where I live at. I didn't know anything about the culture of that area. I wasn't going to talk to anybody. I didn't know anybody. So I sat in my practice with no clients for a long time, trying to adhere to something that has a contextual meaning. And so all of these things that we're talking about, you know, regardless of if we get to all of the slides or I come back, really use wisdom, and the code is a guide, but you have to see what is the best thing for me and for you, and what is the best thing for your client, which really leads us into our beliefs and values. A lot of our beliefs and values based on this profession comes from our code of ethics. And sometimes the code of ethics, if we're being honest, is not quite how we would do this if we didn't have a code, because some of our rules become, somewhat rigid. It protects the client, but also it keeps us from using our clinical wisdom and judgment when it's needed. And we'll talk a little bit about that as well. And again, I have nothing against the code of ethics. It's there for a reason. Typically, codes are created when something has happened and we need to put a rule in place. And then we go extreme left or extreme right. Some codes are getting relaxed on certain things because it didn't make sense. So, specifically with dual relationship, which we'll talk about hopefully a little later. But values are, obtained through our life experiences. There are outward expressions in inner beliefs. These values speak to who we are. There's a parallel process because our clients also have their understanding of values as well. We know that people differ in how they experience pain, how they label symptoms, even though we have a diagnosis that labels everything. Clients come in and they don't label anything at times because some of this is cultural and it comes within their family of origin. We know that there's differences in how we communicate symptoms and how our clients communicate symptoms. The belief about the cause of something is communicated differently, and then the attitudes and expectations towards therapy and treatment oftentimes are not aligned with our clients. Our attitudes and expectations on what's going to happen doesn't always, even when we set goals and help clients set goals, it doesn't always align because of the power differential in how we view the work that we do. So when we think about core beliefs, it affects how we view the world. It's our personal and professional philosophies of choice. It aligns with our personal biases and values. It's our ability to choose freely. Core beliefs also deal with the act on beliefs, the patterns and consistency and repetition that we've learned. It's how we view change, and it affects our behaviors. So we're going to talk through this a little bit. We won't go through all of the areas, but one of the things that I do with my master's level students, with my pre-licensed clinicians, and even those individuals that come back to me for consultation regarding just practice management is we don't get a lot of time to really talk about clients and populations that we don't really like. Oftentimes, when we get our degrees, we go into environments and we have to see every single client because we need our hours and we're trying to do the right things and we want to do well. So we see every client. And so oftentimes we are seeing clients that make us have our own anxiety. We don't know if we're helping them. And so I want you to take a moment and think about three of the most difficult topics for you to be objective about with the client. Either share one, drop them in the chat, and let's just kind of see if there's some alignment with us and how we feel about particular populations. For me, I'll go first. I have an issue with violent partners because I had my own personal experience. So I have to really check myself when there are not just physical violence, but disrespectful language. And so I felt myself in session really have to do some breathing and then allow the couple to do some breathing because that is an issue for me. That's one that stands out for me. If you have one, share or drop it in the chat. Oh, animal abuse, yes. Yep. Thank you for sharing. Ellie said infidelity. Mm-hmm. Child abuse, sex offenders. Thank you for sharing. So I'll make sure that you all get the PDF. Some of these, there's activities throughout that you can, reflect on or talk to a peer about. But this is a good activity. Thank you all for sharing to kind of walk through the process because I do think sometimes we're told to be a blank slate with our clients, but on the inside, our somatic experience is telling us we can't be a blank slate. Our values and beliefs are there, and either we have to go to the bathroom or we feel anxious. So think about, what values and beliefs are challenged with each topic. List one, type of client that you find challenging. Think about the situation. How did you handle it? Because sometimes we are seeing so many clients that we're going through a process and we don't have time to reflect. So this would be a good activity to share. And it changes based on the season you're in your life. I am doing some caring for some aging parents. My father had a cancer diagnosis that reemerged after 13 years. And recently he started going to chemo. He contracted shingles and he has been in and out of the hospital for the last month. He's actually in the hospital now. And the care that he's receiving, like I feel like I am on the phone with doctors and nurses and social workers all day long. And of course, you hear stories about, our healthcare system and this and that. But, my dad is calling me to ask me, can you tell them to come change me? I use the bathroom on myself and I haven't seen anybody for hours. And so I think that, thinking about that now, I would probably have a difficult time working with someone who's having caregiver issues because I will be like, yes, yeah, yeah. And so I won't expose clients based on my current situation because it gets really tough to not feel the feels. So So we want to make sure we're focusing on the client, exploring the behaviors and values and beliefs, making sure that we can address our own personal values, um, and then paying attention to those nonverbals that show up as well. So the other area that I came and shared about, so I won't talk about this area too much. I don't think it's a lot in this training, but understanding diversity and culture. And it's so layered because we're talking about language, we're talking about learning styles, we're talking about you know, you know, the younger population and their cultures within their cultures. Um, and so it's important for us to think about the layered nuances of culture, and then how boundaries that we set are offensive to other cultures. So most cultures are not boundaried as we are. We attempt to have these social norms where we have to do this or not do this. A lot of cultures are very centered, and there are blur boundaries that are deemed as healthy. There's a lot of sacrifice and honor and loyalty and core values. And then saying no, on some cases, is perceived as selfish. So we'll talk a little bit about that because some of these are Western countries that really have some different sets of rules that we have to at least ask the question about so we can understand. So a client showing up to a session late, or a client, wanting to give you, food, or a client not looking at you, maybe looking down, things that we would say, is rude or disrespectful. We have to kind of look at those nuances, and so it's important for us to consider that. Um, like I said, family is at the center in most cultures. The boundaries are blurred, and there are these pieces of sacrifice and honor. Um, so we have a case. We're not going to break into the group. I am going to read the case, and then we'll talk about it, and I'll get your perspective. So Miriam, a married mom of two, fatigued from her work week and yet being asked to host the weekly family dinner. This gathering includes grandparents, uncles, cousins, and of course, mom, dad, and siblings. Miriam rushes to the store, then home to cook a very involved rice and stew dish. The family arrives early, adding anxiety to her already exhausted mental state. Later in the week, Miriam attends her therapy session. Her therapist suggests setting limits and saying no to hosting these events in the future, or proposing that her sister, Sarah, host the next time. Miriam agrees, but she struggles because this would mean making a decision for herself and based solely on her own needs. Although this may be considered healthy by the dominant culture, it's causing Miriam more stress and now added guilt. Miriam may not even feel comfortable sharing these new thoughts with her therapist due to her culture of origin's boundary for respecting authority. She may potentially view the therapist as the expert and the authority figure. So what is your thoughts? What do you do as a mental health provider in the case of Miriam? Now, I'm just going to be honest. I've probably been this therapist at some point in my career because I think sometimes you don't learn until your clients share more. Sometimes we don't get the whole story on the culture. We just get clients coming in saying, my family is doing X, Y, and Z. And then you are going into, okay, well, let's talk about what you can do. And so, what would you do in this case? We know that there's some cultural pieces here. How would you go about helping the client?
I guess first asking, excuse me, what it would mean to her to say no.
Mhm.
And then being able to get a little more information there.
Yeah. Yeah. What is, yes, the meaning of no? Thank you. Anyone else? Has anyone had a case similar to this one?
Well, my thought would be, asking her, to come up with some ideas that may eliminate some of the anxiety on her own and see what she might could come up with.
Yeah. Hmm. Thank you. Anyone else?
I think also kind of exploring the roles of kind of who does what in the family. So is she the oldest child? Does she have on that particular role? Has this always been an expectation? Have there been any differences? And, really kind of understanding how she sees herself and her family and what her role is and what the assumptions of the other family members are of her as this particular person in her family.
Yeah, so helping her kind of understand where she fits, so more exploration of, the meaning of different roles within the family. So kind of taking it off the current situation and helping her gain some understanding. So I like that. Anyone else? I definitely think helping the clients reduce some of that somatic experience from the anxiety. This is probably not the first situation this client had with um, perhaps her uh, family pushing limits. And so maybe the client is exploring what parts of her culture she likes and what parts of her culture she wants to maybe move away from. So helping have those conversations. Also maybe doing some, some role playing, but really, the case talked about anxiety. So if she has to do these things, how can she reduce her somatic experience? So she is still taking care of herself. So there's lots of pieces. Definitely doing uh, gaining some understanding of the client's culture, doing a deeper dive into, the roles and all of the aspects of the culture that has made up roles. That will be helpful as well. So when we're thinking about culturally inclusive practices, helping the client come up with workable boundaries that can allow her to honor her culture, but also honor herself. Definitely using curiosity and compassion, and prioritizing the client's boundaries, but making sure that that is what the client wants to do versus, us prescribing that to the client, and then operating with cultural humility. I think I may have talked about this in the last training. Sometimes I think without having the client do a deep dive in educating us, sometimes it's a opportunity for the clients to learn more about their culture, and then we learn as they learn as well. Having them have some reflective thoughts about, the pieces in a cultural genogram may also help the process. We know that there's lots of cultural influences that our clients come in with, and these are just some of the areas here. Um, Definitely, we're talking about the things that stand out as the time and social orientation, making sure that we understand some of those pieces. Healing practices and cultural beliefs regarding spirituality are pretty important as well as we're thinking about culture. And it's important because we know that in our code, we are being asked to be culturally competent. I think that word really focusing on cultural humility because we're not going to be competent in someone else's culture. Um, I understand why the code has to use that, but we want to make sure that we are curious enough about a client's culture to learn and understand and respect. So, uh, in doing that, we have to understand our own culture, have a willingness to learn, and then embrace others in a way that's not harmful. It matters because we're in a world that's changing drastically. Populations are not as segregated with this population of people over here. Um, and then we know it's an ethical mandate because of our licensing board. We know that clients will have greater satisfaction and rapport when they feel heard, seen, and respected. We know that there's a greater therapeutic effectiveness when clients feel heard, seen, and respected. And we know that ignorance is not bliss. It can cause harm. Clients are misdiagnosed on a regular basis because of something that has not been explored. We see it a lot with kids who get labeled with reactive attachment disorder and ADHD because someone did not explore some other aspect. I know that sometimes in the testing world, um, psychologists have to do a good job at thinking about culture and thinking about those dynamics, but some of our assessment instruments are can be oftentimes biased. So it's important for us if we are seeing someone that has a diagnosis and that diagnosis is passed on to us, that we're being curious about it and exploring it a little more for the client's sake and for our treatment plan because it impacts our treatment plan as well. So we want to pay attention, we want to listen, we want to be curious, and we want to make sure that we're showing interest because we know if we don't, some of these things will happen. Incorrect evaluation, I talked about misdiagnosis, ineffective treatment strategies, long-term trauma to the client, ethical violations. It puts like a red mark on the profession. It's hard enough because we are um, on TV, on TikTok, we get are the butt of a lot of jokes because of just social media. And so it's important to make sure that we are dispelling some of those myths as well as a gatekeeper. We know that techniques, therapeutic approaches, communication, values, self-awareness and flexibility helps with the assessment and diagnosis piece. So it's important to consider that. And that is, all I'll say about culture. Any questions at all before we keep moving? We are probably going to take a break in about 10 minutes. Any questions at all? All right. All right, so let's keep moving. As you can see, these are some areas that I found important. So what I didn't tell you at the beginning, at one point I was working on my PhD in counselor supervision and education, and my research was going to be on counselor readiness to practice, counselors that were in practice for 1 to 5 years. And so I started to do the research by seeing these areas. So a lot of the areas that I'm discussing came from that research. I did not finish because that PhD was about to kill me and it was too stressful. And so, but I still continued to do the research and I created this training because I think the research is the research. Um, it matters. So a lot of these topics came up when I talked to clinicians about not being aware of these areas. So we're going to dive into a few of these. I'll touch on one before we get started. Informed consent, self-disclosure, dual relationships, boundary crossing, a little sex, couples, and termination. Those are some of the hot areas that came up. We know that our informed consent is it's our duty to share our duty to communicate any changes in the informed consent. We know that we're in this ever-changing environment when we have telehealth and different, hacks and things going on, that we need to communicate that in a way that clients understand our stance on it. And so, what I would say about the informed consent, as things happen within the agency, or if you're noticing something with the client, even if you don't are not the decision maker on changing it, don't just keep quiet about it. Talk to the supervisors and say, I am noticing this with my client on a regular basis. I think we should add something to the informed consent that helps guide this conversation better. Um, because if it happened once, it's going to happen twice, and it's going to happen 3 times. So it's important that we have a unified front as far as informing clients. Some of the challenges that we think about in maintaining boundaries as it pertains to informed consent is being self-aware of our own feelings and behaviors when we have to share information, being observant of behaviors of others in the helping profession. We definitely want to act in the best interest of our clients and our families and ourselves. We want to be aware of our own value conflicts. And most importantly, we want to make sure that we're not harming ourselves or our clients. So we talked a little bit about self-disclosure. Self-disclosure is an amazing therapeutic tool that works when it works. When it doesn't work, it's because it exposes your lack to the client. It is in excess to the client. It is irrelevant to the situation of the client. Um, it's costly to the client, and it's detrimental to the client. I'll give a quick example of when this went wrong, when this can go wrong, and then we'll get ready to break for lunch. I have 1 or 2 more slides on self-disclosure, and then we'll stop after self-disclosure. So I provide trainings for PESI, and prior to COVID, I would travel throughout the United States. And so typically I would do 3 cities back to back to back, and then I will fly back home. So on the third day, I am tired. I am putting a blanket over my head and trying to go to sleep until I get back from Georgia. Um, you're talking to, 50 in one class, 20 in another. So it's a very intense 3 days, same topic on boundaries. So this one particular time I was uh, in the middle seat, maybe coming back from the West Coast. So I was really tired. I had a nice young lady sitting to my right who says, "Are you from?" Yeah. I was like, "No, I was in town doing an ethics training." And she said, "Are you a counselor?" And I said, "Oh, here we go. Here we go." So I said, "Yes, I am a counselor." And so she proceeded to share with me her experience with her counselor, who she was helping um, go through a divorce. Now, this is what she said, y'all. And I'm trying to keep the straight face and just listen and nod because we're in the air. And so I don't have a duty to warn or do anything because I am flying back to Georgia. So she proceeds to tell me she had been seeing this clinician for about close to a year. And towards the end of that time, the clinician her presentation started changing. She started sharing with the client about her divorce, and the client started listening. She was happy to listen. That's what she told me. And so I listened a little more with a straight face, and finally the person sitting next to me said, "Well, it really wasn't a big deal anyway, because I really wasn't ready to do that work." That really stood out to me, y'all, because I definitely think that a lot of times self-disclosure really keeps the client who's fearful of doing the work, it keeps them in that place. So self-disclosure in and of itself is not an ethical violation. It's used to therapeutically build rapport with clients, but oftentimes there is this, it's either I don't want to do it because I'm not supposed to do it, or I'm doing it too much. So that example really hit home for me. Um, Thinking about self-disclosure, I want to think about what is appropriate, what's inappropriate. Um, my thoughts about that is you get to choose that. It used to be you couldn't have anything in your office. It had to be clear walls, and for some that works. For me, I have a lot of personality, and I'm going to be in this office all day. I don't want clear walls. I want stuff on my walls. Now I'm going to be respectful, but if a client is looking around, talking about the things on the wall, that becomes a part of the therapy session, and we're going to talk about it. Oftentimes, my clients would say, I'm sleepy, I'm tired, I don't want to come. But I felt comfortable choosing this place that I'm at most of the day to have some representation of me, some representation. So there's ways to self-disclose without self-disclosing. You can have a story, and it doesn't have to be this is me. Thinking about cultural implications are pretty important as well. Any questions about self-disclosure before we wrap for lunch? Mhm. Looking at the chat. All
No.
right, so can we round it to 12:30?
Yes, that sounds good.
Hello again, everyone. I hope you all had a great lunch. I did absolutely nothing and looked at my watch, and it was time to come back. I'm like, oh man. You just sit there kind of staring, and you're like, oh, the time is over. So no worries. Today is actually my Friday, so it's no big deal. So let's dive in. Let me make sure this is in full screen because it looks kind of wonky now. Make it bigger or bigger. All right. So uh, let's talk a little bit about dual relationships. First thought that comes to mind, drop it in the chat. Your thoughts about dual relationships. First word that comes to your mind, just drop it in the chat. Or take yourself off mute if you want to talk.
It's a quiet group after lunch.
I know, I understand. I'm not gonna press them too much. I'll go. The first word that comes to my mind is misunderstood. That's the first word that comes up for me. Anyone? Complicated. Yep, that's a good one, Samantha. Um, I'll let you all kind of chime in as I continue. So the question is, are dual relationships always unethical and prohibited? Suzanne said she was thinking difficult, but complicated is a better word. Yeah.
I also
So go ahead, Elise.
I also think that they're misunderstood, but that in some communities, they're it's not possible to avoid. So that's why it can also be confusing because it's easy for those of us from large metropolitan areas to have rules about that versus someone from a smaller community.
Yeah, that brings up a great point because we have this one code, and the code is not broken up in various communities, and so I do think that it becomes unfortunate because sometimes we as clinicians are judged by this overarching thing, and it really does vary, which is why I've learned that if you're able to state your case in a way that really speaks to some of those nuances, the board is really a lot more welcoming. Um, And so I think it's important for us to have the conversation. So Matthew said, depends on the situation. I live in a small area in Virginia, and it's the same way. Yes. And it really does depend a lot of times. And so one of the things I've noticed with the code over the years for LPCs is went from dual relationships to multiple relationships to professional interactions, because I think what the board is attempting to do is to humanize the fact that we're going to have opportunity for an interaction. It's really just how we communicate it and what do we do with it. Sometimes we don't even know that we're entering into dual relationships or in a dual relationship until it's way late. So, do you end the therapy relationship? How do you manage those pieces? Because we are all in community. Some of us go to churches and fitness centers, and we have connections. We can't know everyone's connection. So sometimes it's an innocent thing that happens, and it's important for us to really make meaning of those times. The example that stands out regarding dual relationships is a clinician in Alabama. She was in this same training. She shared with the group because it was important for her to share the when and then what happened that was out of her control. So she went to the board in Alabama and asked for permission to, it was really bartering, but you're entering into a dual relationship because of the bartering piece. So she asked for the benefit of the client if she could barter services because her client had severe PTSD and a lot of diagnosis, and the client was losing her insurance. She told the board what the stipulations are. She wanted to barter. Her client was a dog groomer, and she wrote everything out specifically, and the board approved it. So she did everything right. She asked for permission. She wrote out what was the terms. It was going to be a short, limited time, and her client was looking for more insurance or looking for a better job to pay for the insurance. The board said document the time and move forward with this bartering experience. Things were going well until things were not going well. Probably 2 months into the bartering therapy relationship, the client cut the clinician's dog around the neck, and the dog ended up having to have some type of procedure, and things went left very fast. Um, the client was very distraught, and it sent her into a tailspin, and the therapeutic relationship was ruined at that point. The clinician felt guilty and had her own experience as she was sharing the story. So, in some cases, when we're doing things that are in benefit for the client, it oftentimes can still backfire. So, to answer this question, are dual relationships always unethical and prohibited? It's no, but I do think we have to have some careful consideration when we're considering. We have to think future focused to see what other possibilities. So the clinician was very honest. She said we couldn't rectify the situation. Her dog almost died. The client was she was ashamed, and the clinician, beat herself up for a long time for even entering the barter relationship, but it was to help the client. Uh, the clinician already had a dog groomer, so she was really trying to help the client. So sometimes our limits is with ourselves on how far we can help. And we are, I call us hearties. We lead with the heart sometimes. And in that case, it did not serve the clinician, the client, or the dog well. So that was an example that stands out. Does anyone else have an example that um, they are willing to share? All right. Well, we're going to watch a video. I'm going to stop the share to make sure that the sound is on. Can y'all still see the video?
No,
Did it
there's no
go?
video up.
Okay, I got to do a new share. I got it. All right. So the short clip, I did get, I don't think I put it in here, but I did get approval to show this clip. I think I talked to your person about it previously, so I think we're good because I showed pieces of this one before. So this is a very old movie. It's called Prime. And this clip really speaks to multiple relationship dilemmas. We'll get a chuckle out of it and then talk a little bit about it and we'll keep moving. But in essence, this kind of speaks to what happens.
So what the hell am I supposed to do now? End treatment? Keep going? Bring them in for a couple session?
Well, if this doesn't go anywhere,
And I really don't think it will.
then you'll be relieved you stayed with her now. If you end her treatment and they break up after 2 weeks, you will not have served her best interests.
It's incredible. It's amazing.
I'm sorry, your bra is showing. Is it missing a button there?
No.
No, that's the way it is.
You are so right about Jewish men. I mean, so attentive. I mean, of course, you're married to one.
Yes, but he has ADD.
I just can't get over it. I mean, I feel a little awkward telling you this. I can't tell anyone else. So, we have had sex on every surface of my apartment. I mean, I haven't had much sleep, but he's just so eager to please me. And I feel the same way about him.
Oh.
He makes me want to do things
I understand.
that I've never wanted to do before.
I got it.
He hasn't had much experience. He's only been with 2 other women.
What? He's had sex with 2 other women?
I just have to say this because I am too embarrassed to tell anyone else. His penis is so beautiful. I just want to knit it a hat. Did you ever think that I would be this satisfied? I mean, sexually?
Not like this. Are you using protection? I'm sure his intentions are pure, but he doesn't sound like he knows exactly what it is he's getting into.
Do you think I should just cut it off right now?
I'm not going to answer that. We need to talk, Rafi.
Okay.
He's my son.
Who? You betrayed me.
Now we're having a conversation that will very likely end our work together. Can you see that I wanted to avoid having this conversation for your benefit?
No. I think you did it to control your son's life.
All right, y'all. Sorry that was a little low. For some reason, I don't know why. It's always louder, but these systems, they do what they want to do behind the scenes. So, but hopefully you heard the essence of the case and really saw in this situation, this was her son, and she wanted to get information, but the the sentiment regarding the dual relationship is that sometimes there is a betrayal when the client doesn't know. And so it's important for us to consider those pieces as we're thinking about dual relationships. So you all will get to practice yourself. So we do have a case. We're going to go into our breakout rooms again. I will read this case, and I would say take a picture of this because there is a second part with the questions to consider that I want you to process. So take a picture of this as I am reading it, and then we'll go into breakout rooms for 15 minutes. So Dr. Sarah Johnson is a licensed clinical psychologist working in a small community. She has been seeing Emily, a 35-year-old woman, for therapy for about 6 months. Emily initially sought therapy to address anxiety and stress related to her job as a high school teacher. The incident. Sarah recently decided to take up yoga to manage her own stress better and signed up for a class at a local yoga studio. To her surprise, the yoga instructor is Emily. Emily recognizes Sarah immediately, and after class, they have a brief, friendly conversation about how they are each other's student in a way. Escalation. Over the next few weeks, Sarah attends Emily's yoga class regularly. They start to chat more before and after classes, and Sarah notices that Emily's demeanor and disclosures in therapy have changed. Emily begins to share more about her personal life and struggles during her yoga sessions, sometimes even touching on issues they discuss in therapy. Dilemma. Sarah is concerned about the dual relationship that has formed. She notices that her objectivity in therapy sessions is being affected. Emily is opening up more in the yoga setting, and Sarah feels torn about how to manage the boundaries between their professional and non-quasi-social interactions. So we're going to go into our groups. It's 12:45. We'll go into 101 because it may take a few minutes for us to get in there. But here are some of the questions I want you to consider. And I'm going to leave these questions here. I'm going to make sure the questions enter into the room. So if you didn't take a picture of this, take a picture of the case, and then we'll go into the rooms, and I'll make sure the other one gets in there.
All right, I'm going to put everybody in breakout rooms. Please just accept the invitation.
All right, everyone. I would love to hear about some of those juicy conversations in your groups. Anyone that would like to share, that would be great. I would love to hear from you.
Is Stephanie, you back? I know me and Stephanie were group 3.
Yes, I'm here.
Okay. Well, I mean, I'll jump in, and we were both talking. So we were talking about risk was the the relationship from the beginning was compromised, and it disrupted the therapeutic process. That's kind of what we're talking about, because she had an opportunity right at that first class, because she could have went where she would have taken the class, and then at the end, this could have been discussed at the next session or at the ending of the class. But it basically, so basically, she had opportunities to try to kind of realign or reestablish the process. She continued to go to the classes. We also talked about how she accepted, and they identified being the student and teacher in their perspective dual relationship, and then too, at this time, there's concerns because of so much self-disclosure, and as well as, so for her to kind of reestablish this relationship, if she were to transfer to another therapist, the client might feel abandoned, hurt, she did something, so those are some of the things. I don't know, Steph, if you want to add some more stuff.
And I think, she really could have addressed it, in a clinical supervision, that, and it doesn't look like that appeared to happen, but that probably would have been a really good idea to maintain the professional boundaries, but she just repeatedly kept meeting up, and they were meeting up, for this particular class. So,
Thank you, Stephanie. Anyone else? Any other groups?
So our group talked about we talked about if just taking the yoga class was a dual relationship. We were sure that, like, when they did all the talking before and after, that could be problematic, but we talked a little bit about just taking the class. We talked about if Dr. Johnson really needed the yoga, and there were no other yoga classes, but then Emily asked Dr. Johnson not to take the class. And then we went to making it a little more difficult than just a yoga class. And we talked a little bit like maybe they met at a church or something where it wasn't so easy. Because at the yoga class, we were like, well, as the professional, we should probably step back. But then when it was church, it wasn't so easy just to never go. And so we talked a little bit about that. Like, it got harder.
Yeah, yeah. Yeah, we can go down the weeds with this example. Thank you for sharing. Anyone else?
There was one thing me and Stephanie, we talked about, obviously, I think also what you guys are saying, there's multiple opportunities to realign this, reestablish this. But I think stepping into the yoga class, that was unintentional. I mean, that's kind of reality, like you said, grocery store, church. And so, like you're right, because we talked about that, what if she was going to your parish? And so, but I think the piece here that it appears she never sought clinical supervision along the way to help kind of steer or guide her. And so that was kind of interesting on why, and not knowing just what, kind of, face value. So
Yeah, yeah, it's definitely loaded. And these happen, all the time. I sit on, boards and we look at these cases and things of this nature. And sometimes when we're looking at the case, we're like, oh my gosh, there's glaring things.
right.
But they're so nuanced at times, and there's so many subtle things that pop up that we don't consider. And so, um, is there another group that wants to share anything that you thought about, anything you're curious about? Right. So this was not, this was a case. This wasn't any case that came up in supervision, but I have a case that is different but similar, and you can critique my approach and how I handled it. So I had a client that I had been seeing for quite some time, um, and interestingly enough, what we worked on a lot was boundaries. I have a book on boundaries. I've done a lot of work around just boundaries in general, women and boundaries, all types of things. And so the client particularly came to me for that reason. There's stuff on the website that talks about that's the work that I enjoy doing. So we have been working on boundaries for quite some time. Because I do these trainings, I typically, when we were in person, I used the local Office Depot to print, like, all of my handouts and packets and things of that nature. And so I send them ahead of time over email. And so when I arrived to pick up the packet, my client was the cashier. I spotted her from a distance. And so, that's not an issue, I think, because you're going to see people. But what was an issue happened right after that. So the line was very long, and so it was probably 10 or 11 people in the line. And so my client spotted me. And before you know it, the client said very loudly and waved her hand, "Hey, Miss Matthews." And everybody in the line looked at me. And of course, I'm doing a like this, and I'm just wanting to stand in the line. And so after the line wasn't moving, she waves me to come up and says, "Your items are ready." So apparently she was the one who was either printing my items or she recognized my name and chose to print the items. And she was like, "You do not have to stand in the line. Your items are ready." Now, I don't, know if this is how this Office Depot does it. You come up, but because she knows me, that's the reason she's doing this. And so to keep her from screaming over all the other customers, I get out of the line and go up towards the, and she proceeds to say, "I finished your packets for you. It's very insightful information in these packets." And then she whispers to me, "You don't have to pay anything." So it even gets more complicated now because I am her current therapist. And now she's saying to me, "Oh, this is my kind of side hustle situation." So she's disclosing to me that she's stealing from the store. So I did see some consultation on this because this is getting really layered. Um, and so one of the things that came up in consultation was, what is my role while I'm in the store? What is my role in the therapy session, in the therapeutic space? And how can I handle this with grace? Because my first thought is, I'm telling her, you don't be stealing from the store because that's the customer side, but also just it was a lot of layers, and I had never experienced anything like that. And so, I did some consultation with several peers and old supervisor because at this point, I cannot go back in the session and not have the conversation. Something had to be said. But I wanted to make sure that it was with grace and compassion and not judgment, and that I set a clear boundary around um, my comfort level of going into the store feeling like she's giving me this break, which she didn't see any problem with it. To be honest, I can tell that she was honored to do that, and so I did that. She came in for a session. I was really quite nervous, and I had been practicing for a while because there was lots of things going on, and I had to really think about what my role is as a therapist and how I could really turn this into a teachable moment, but also really outline, what's appropriate for me and what's not appropriate. Um, because if she had shared that she did that type of did that, then it wasn't me. How would I handle it if she came in session and said, "Yeah, sometimes I give freebies to customers when they come in." And I started thinking about, okay, I'm not mandated on that front. And so I would hold space for that information in a way that I would hold space for it, right? So we had the conversation. She actually brought it up, but she didn't bring it up for the same reasons I was bringing it up, and it was a very loaded conversation. And so I was able to set boundaries with, letting her know she doesn't need to do anything for me if she sees me in the store. And then I decided to actually go to another Office Depot. I found out that she was a floater. And so then I decided to change where I was getting my printing done. And that was easy to do. That was not a big deal to just change printing companies, to avoid any of that. But sometimes we can't avoid. If I've been going to a church 10 years, I'm not changing churches. I'm just not doing it. And no one should ask me to do it. And so then we have to have conversations about with our clients, what is the rules of engagement when we're at service? What if we're in a women's group? What are the rules of engagement? And really having some really authentic, healthy conversations about it, and not changing churches and moving hundreds of miles away. I have had clinicians say, I was the only psychologist, and the only thing I could do is just pick up my family and move 300 miles away. That is not fair to us. I know we need to support the clients, but we also need to really think about how can we have these conversations. At one point, I put some information in my informed consent and on my website about what is a dual relationships. Clients don't necessarily understand that language, and so really explaining that in a lighter way, so clients don't feel like you know they're being reprimanded, but also it's for our protection as well. I also was out with a friend. We were having a margarita and some salsa and chips, and a client brought 8 of their family members over to my table, and and I was out. I wasn't working. And so we also have a right to just be out as well. So it's not just about protection of the clients, it's protection of our family, and friends as well. So that's the thought. If you have to enter into the dual relationship, when there's no other way around it, you want to think about these questions: is entering into the relationship in addition to the professional one necessary, or should you avoid it? Can I, can this relationship potentially cause harm to the client or to you as the clinician? If it seems that it's unlikely to cause harm, would the additional relationship prove beneficial, and to who? That's pretty important. Is there a risk that the dual relationship could disrupt the therapeutic relationship, and can I evaluate this objectively? So those are some things to consider if it had to happen. I know in rural areas, you know, this happens all the time. It's done, and it's done with grace. And it's also done because there's no other clinicians. And so, thinking about how do you structure that when you're the only one? How do you separate things? It's going to be pretty important, making sure that you have some type of treatment plan to determine, how this dual relationship is going to look, and making sure that you think about that and consider that as well. The other area is boundary crossing. Boundary crossing is not unethical, and so there are numerous examples when boundary crossing is beneficial for the client. That could be visiting a client in a hospital. It could be, for some, going to a recital for a client who has extreme anxiety, perhaps sitting in the back, not making yourself known, but really, in support of a client. Uh, there has been situations, and it varies from state to state, where clinicians have, accompanied on some level a client going to a burial site. Lots of ways that some of the boundary crossing can be therapeutically beneficial to the client. So just really consider your state, your code, and your morals and values as well. That comes into that also. We know that the big area that was always discussed is this slippery slope to sex. I won't talk too much about sex because although sex is a no-no, there's so many other things that happen before sex. We got attraction. We got people coming in with good smelling perfume and cologne that makes us think about someone else, that makes us like the client more. We have voice tone. We have personalities that are similar to others that cause countertransference, and it caused us to value one client over the other. And so if we're thinking about sex, sometimes it's an innocent start and sometimes it's not. Some of these things that I just discussed kind of pop up. And then we go to physical contact and then dating, and then it goes left from there. Any questions about dual relationships, um, sex, anything that we've discussed thus far? All right, all right. So we're just about to hit 1:20. We're going to take a 5-minute break and come back at 1:25. And then we'll finish up for today. I'll go over a few more slides. I'm going to stop at about 5 or 10 minutes till to answer any questions. And then I'll definitely come back for a part 2. Okay, y'all, we're going to just dive in to talk about couples a little bit. Put a 1 in the chat if anyone works with couples or families. Couples or families. Let's see. Couples. Let's see, a 1, okay. So, yep, there's some ones coming in. So, give me one word that describes your feelings about working with couples or families. Yeah, those are some of the words that I've used as well. Demanding, challenging, difficult. Yes. All of y'all were, all of your things will hit the board. Tiresome, rewarding, complicated, unbalanced. They could be exhausting at times. Sometimes they're exciting when we see ahas, but they do bring up lots of emotions. Um, and they also bring up lots of assumptions. So let's think about what are some of the assumptions that you or your client might have about families or couples counseling. Sometimes our clients have assumptions, and then even when we started out, we may have had assumptions as well. If you can think of any assumptions that you may have or your clients may have about the family and couples work, you can drop those in the chat. As I share some of the assumptions, particularly about couples and families. I'm, kind of putting them together. Engaging in couples therapy means we'll work things out as a couple, and that's very similar to a family as well. Just because you show up and you want to do the work, it doesn't necessarily mean that the couple sessions or the family sessions are going to work. Sometimes um, we finally we will finally have somebody who sees my side and shows my partner or my family that it's their fault. So oftentimes our clients want us to be on their side so they can get their point across. The other assumption that I've seen is that it doesn't matter if my partner isn't interested in therapy. As long as I'm invested, it will be successful. So very similar to families, that is an assumption. And then, I mean, we're going to get a divorce anyway, so therapy is a waste of time. So that is another assumption that has come up. Can you think of any other assumptions that may stand out? Let's see here.
Someone wrote that it'll fix all the issues.
Yep. Mm-hmm.
The therapist is going to immediately fix the situation.
Mm-hmm.
Powerful therapists.
Right. So the biggest thing about the families and couples work is really identifying who the client is. Specifically with couples, it's important to make sure they understand that, if you're working from a systems approach, that the couple is the client and not just one part or the other. Similarly with families, oftentimes there isn't an identified client, but making sure that each party feels heard or seen and respected. I have a whole training on couples and families, and so I only put one or two slides because I knew we were running out of time. But it's important to kind of know what boundaries you need to set for both couples and families, because since you're dealing with multiples, it can get very gray very quickly. The other area I want to discuss is termination, an area that I think is not talked about enough. And so we're really going to just spend a little time on it. But interestingly enough, there are tons of code that talk about the termination. We have abandonment, which is really big. We hear that shared a lot. I don't want to abandon the client. We have this badge of honor that we can't let the client go. Um, Treatment disruptions falls under termination as well. Non-payment of fees. If there is a fee involved and you're not rectifying the fee, the board will look at you having boundary violations because you're probably not doing that for other clients. So you want to make sure that you're thinking about um, your policy so that this termination piece can be talked about at the onset. And so all of the code really talks about different ways to terminate. So we're going to briefly talk about, and this may be a good area as we're talking about termination to wrap, depending on how far we get. Forced termination. Can anyone think of any time, any clients that you had to do a forced termination with? Drop a little of the content in the chat. It can be high level. Or if you want to take yourself off mute, please share. Anytime you had a forced termination.
Well, if a client gets arrested and has to go to jail.
Yep. They relapse and they go to jail or something of some sort. I had a forced termination when I was actually working with a couple, and uh, the husband uh, attacked the wife in session. Uh, that was a forced termination. First, he said something inappropriate to me, but then he attacked the wife, and I had to actually call the police. That was a forced termination with a lot of paperwork attached to it. Um, any others? Can you think of any other forced terminations?
Someone wrote the therapist determines the patient is not benefiting from treatment. The client no longer meets criteria for services per the agency standards that you're with.
Yeah, the one about the therapist determines that the patient is not benefiting from treatment. That is really a good one, because oftentimes clients feel, I mean, they have the right to keep coming. But if something were to happen and we get audited, that is a good piece to really consider, because if we don't think that they are doing the work, then we are really in jeopardy of insurance fraud if it's insurance, because we are seeing the client and the treatment is not lining up with what we said we were going to do. And so that is a great example of making a clinical judgment and really, bringing the client into that conversation as well. And then I like Stephanie's, the client is no longer meeting criteria for services. The other ones that I've seen is the client's presentation, all of the things that they want to work on. They come in with a history of trauma, and they have, PTSD and all these other things, but the client is unable to really come to therapy on a consistent basis. Um, so it's difficult to work within that confine and really help the client. So some others are ethical violation or conflict of interest that could cause forced termination. The therapist feels threatened, and then the therapist is working outside his or her scope. Some anticipated reactions. The client may feel anger toward the counselor, perceiving the end of the counseling relationship as abandonment. Um, I don't know if they would use those words, but clients will feel that they're losing a relationship. Clients may feel anxious at the thought of having to handle things on their own without the support they found in the therapeutic relationship. And then clients might feel sadness at losing a relationship upon which they have come to depend on. Some may feel indifference at the end of the relationship as well. Stephanie said the client remains distracted during the session, playing on cell phone, leaves the session. Yes, Stephanie, you are talking about all of the things, which is why I don't work with kiddos anymore. During the pandemic, the kids were holding the phone, it was upside down. I was like this. It was really distracting and non-therapeutic. They didn't have a stand. They're playing on the phone. They're not looking at the screen. And so you're right. We have to make those clinical judgments as well. And then the counselor reaction. Sometimes we feel guilty. Sometimes we feel frustration. Sometimes we feel our own loss and sadness. But oftentimes we feel a big relief when clients go away. Then we have the client-initiated terminations. Again, they terminate because they determine that their goals haven't been met as well or have been met. They feel that their problematic symptoms are minimized or gone. Can you think of any other client-initiated terminations? Let's see. I think I have one that stands out. It was from some time ago when I was working in the community, um, working with a young girl, and was really impactful. She was changing her behavior. She was staying with a aunt who was now her guardian. Um, and so she had to go through therapy because she was going through the Department of Family and Children Services. And the aunt got jealous because the client was more connected with me than with her. And so she initiated the termination. So it was random, but they initiated it. So Matthew said, I found it challenging when the client has a goal, but the family spouse, they're included in the sessions, have different goals for the client. This is very challenging. Yes, I would agree with you that it's really hard to navigate that piece. The client wants a different therapist. Yep, that's a good client initiated termination. Uh, some of the anticipated reactions are insecurity, guilt at times, and then some of the other reactions are resistance, fear, and anger. And then we have some strategies. So strategies to really think about termination. We want to address termination issues, and I would probably change that, and I will address termination at the beginning during the informed consent, so it can be a part of the talk about goals and treatment planning. Oftentimes, I would say we're going to come up with your exit strategy, and then clients will laugh and say, "Well, wait, I just got here." And we really, talk about, the reason why these goals, it's really attached to termination. It's not just we're doing goals. We want them to, set boundaries and be advocates for themselves and live their best life and have a fulfilling life. But really, the goals are attached to the reason why they exit our office. So if we pair those together, clients will be, whether they have issues with disconnection or abandonment, they will know that the goal of our experience is to end our experience at some point. And so oftentimes I'll ask at the beginning of our work together is, do you have an issue? Do you have any problems with endings? And I'll find that out early on, so I can understand what work I need to do as we're preparing. Sometimes it's the ending with all things, all people, and sometimes it's the ending of relationships that the client may not have healed from. And so it's important to really have that dialogue to understand that in the beginning. So you will not get clients that are coming up with new goals after you've worked on five or six. They're like, I'm not going anywhere. I have a new goal that I'm working on. And you won't have issues if you have to report to insurance about, why are you seeing this client this many times? You're seeing the clients 2 times a week and their presenting problems are like not life changing. And so it's important to think about that. Reach an agreement on the goals. The other big piece that I have started researching and doing a lot of my own CEs on is possible psychotherapy initiated terminations. We have lives, we have illnesses, we have people that we're caring for, we're aging, and oftentimes we have to be away from our clients. And so making sure we have our paperwork, our professional wills, we have our point of contact, our therapists who will work with our clients if something were to happen. It's important for us to have those pieces in place, whether you're working for an agency, a private practice, and an agency. It's just really important. We want to be mindful of client and other initiated interruptions in treatment and making sure that we document as best we can. Sometimes clients leave and we don't know they're leaving. We just don't see them. And so making sure we document, that ending, whether it's a short ending. And then we want to be clear on what abandonment is and what it's not. And then we want to have ongoing discussions with clients about their progress in treatment towards termination. Any questions about termination at all? Anything I can answer? All right. And then this may, Karen, be a good place to start. The next one is about, it's a loaded topic. And so I don't think I can pick one thing out to kind of dive into without giving into a whole section. So I wanted to see if there's any questions that I can answer for anyone, anything you're curious about, anything that we didn't talk about that you want to get some insight on. I will surely answer you.
Wait a minute. I just thought of something with regards to termination. And then you have, like with our agency, we have clients that have family members that are calling back saying, no, you can't terminate. And when we try to ask them, well, what are your needs? Please describe what are your needs. We need help coordinating. Coordinating what? Like they're not able to really discuss what their needs are. Like the service has been terminated for counseling or for whatever it is. And like then that just becomes like a persistent, ongoing kind of situation. So this is kind of what we are dealing with right now. It's been really interesting and challenging. And then they then try to figure out other past situations. They'll bring up other past situations. Well, wait a minute, I want to work on this. And that was already addressed. It just becomes like an ongoing adventure.
Yeah, so is it that they um so what's your take? Do you feel like they're not ready, or do you feel like they just enjoy talking to you? What do you think what do you think it is?
The take is they also work with like the community psychiatrists that we have, and so they're trying to angle to continue with the community psychiatrist, and then they'll, I mean, for lack of better words, they'll start making up problems just to, I mean, that's already been discussed, you know, in sessions and whatever else, but they'll try to make up any type of scenario just to continue with that particular psychiatrist. And, you know, that's been closed. This has been closed. Therapy's been closed. Okay, we can recommend an outside provider. No, they don't want the outside provider. It's like a level of comfort. Then it's, yeah.
Yeah, that definitely happens. So I can see how challenging that is because, ethically speaking, you need to terminate. And I think oftentimes clients don't understand. I mean, because they're wanting to get their needs met on some level,
Mhm.
um, they don't understand, and quite frankly, they don't care about the dynamics that puts us in by continuing to see them. So, yeah, those are some tough boundaries to set.
Yep.
Thank you for sharing that. Anyone else?
I have a question.
Sure.
In the beginning of your in the beginning.
In the beginning.
I don't remember what was on the slide, but you had mentioned something about the difference between training in the north and in the south, and I wondered if you could just elaborate a little bit on that.
Yeah, I think what I've learned, because I've kind of been all over, is that, and even sitting and reading cases for boundary violations or someone that has to go before the board, one of the things I learned by doing that work is that the people who are reviewing cases, they look at the case, they look at the code, but then they look at the culture of the community. It's like, what do we do in this community? Like, what is the norm? So it almost, that piece is just as important as what the code says. So if I am looking at, you know, in the North, in this particular culture, boundary violations are not as strict as maybe somewhere in on the West Coast. So it's also in our master's programs, depending on who you were trained under, what theory, what motto, what lens they're looking through as well. So if I noticed that sometimes when I go to California and do trainings, their board is really strict, but the clinicians are really relaxed. There's a really nice vibe there. And so, but then I go to other places and it's, we need to do it this way. It's, we were taught this way. And that tells me that the culture of either the university in that area or even within disciplines, there are different views on what boundaries look like. I have lots of friends who are social workers, and because they were in, the community doing work, because that's what social workers do, boundaries, although in the code there's some strict lines, but you're social workers in the field, and so there are some boundaries that look differently. So I guess that's what I meant. I have learned that, oh, in Georgia, this is our philosophy on these things, as it pertains to clients. And then I go to other communities and they're like, yeah, that's a thing, but we also expanded, which really is confusing because you're working with a client that comes from another therapist, then we have to re-educate that client on we don't do it like that here. And they'll say, well, my last therapist, this was not an issue. And so I wish in some levels we would have some some more unification so that the profession stands on its own without all these variances. Then we have, there are ethical violations because people are committing them, but then we have, oh, we're going to do it over here, and then no, you can't do this over there, and then so that's what I mean about. I hope that that lengthy explanation helps you understand.
Yes, thank you. I used to work in the community. I'm a social worker in the community for a nonprofit, but now I work in a mental health agency for the county. And so, yeah, it is very different. And it took me a little while to get used to, being in an office setting.
Hmm. Yeah, when I did assessments in the hospital, they the hospital system did not, so our role was to do the assessment, but there was really no value placed on our licensure. And so there was a lot of fighting with nurses and doctors about our criteria for suicidality because they were concerned with the bed. They wanted the next client in because of what the bed meant to them. And I wanted the client to stay to get a higher level of care. And so I do think that there's just different views about our work in different places. So we got to pivot and understand, but also set our boundaries as well. Any other questions at all before we close today? And I'll make sure you all get these slides here, and then hopefully I will be able to come back and do the other part to this training. All right, Karen, do you need anything else from me? Anything else you want me to say or do?
I do not. I'm just making sure everybody put their name, email address, and agency in the chat so we can make sure that we get you the slides Ms. Matthews provided, as well as your certificate and a survey if you wouldn't mind filling it out. Just stay tuned to the Region 5 website so we can update you on future trainings. And one of them, we will hopefully be inviting Ms. Matthews back to do part 2 of this particular training.